Good afternoon, dear students. Our topic, Angina pectoris, one of the variants of ischemic heart disease. According to international classification of ischemic heart disease, occur 6 variants of ischemic heart disease or coronary artery disease. First variant, sudden coronary death. Second variant, angina pectoris. Third variant, acute myocardial infarction. Fourth variant, painless myocardial ischemia. Next variant, heart failure and disturbances of rhythm and conductivity. If you remember, coronary circulation characterized by next information. Coronary arteries supply blood to the heart muscle. Right coronary artery supplies both the left and the right heart, and the left coronary artery supplies the left heart. And coronary circulation characterized by two main arteries, left coronary artery and right coronary artery. And left coronary artery divided on anterior interventricular artery and circumflex artery. Left coronary artery divided on anterior part and circumflex branch of left coronary artery. What does it mean? Ischemic heart disease or coronary artery disease. Ischemic heart disease is the most common form of the heart disease and the single most important cause of premature death in all world, in Europe, Russia, North and South America, Australia and New Zealand. Ischemic heart disease due to imbalance between myocardial oxygen supply and oxygen demand, which is associated with atherosclerosis of coronary arteries in 95 to 96% of all cases. One of the variants of ischemic heart disease, angina pectoris. Angina pectoris is the clinical syndrome caused by transient myocardial ischemia and may occur whenever there is an imbalance between myocardial oxygen supply and demand. The most common form of ischemic heart disease. Angina pectoris is the medical term used to describe chest pains caused by poor blood flow to certain areas of the heart muscle. Often the name is shortened to angina. Having angina means patients have an increased risk of having a heart attack, myocardial infarction. Angina can be useful a warning sign if it makes patient seek timely medical help and avoid a heart attack. Prolonged or unchecked angina can lead to a heart attack or increased risk of having a heart rhythm abnormality that could lead to sudden death. And narrow of coronary artery due to atherosclerotic plaque caused by angina. Typical chest pain, which characterized by burning, pressing or squeezing substernal pain. Risk factors caused by ischemic heart disease. And all risk factors divided on two main groups: non-modifiable, uncontrolled, and modifiable risk factors, controlled risk factors. Non-modifiable risk factors: age, more than 45 years, male gender, family history, genetic predisposition, and ethnic origin. And modifiable risk factors: controlled risk factors, dyslipidemia, arterial hypertension, smoking, diabetes mellitus, obesity, fatty food diet, physical inactivity, stress, hyperestrogenemia in females. This patient suffered from ischemic heart disease because he had some risk factors such as man, more than 45, smoker, with obesity, and with fast food diet. Etiology of coronary artery disease include at first atherosclerosis. In as many as 96% of all cases, at least one blood vessel of heart has severe coronary blockage. Critical blockage of a coronary artery from atherosclerotic plaque buildup. When cholesterol or blood fats are too high or patients have other risk factors, a fat-like material called atherosclerotic plaque builds up in blood vessels. Eventually, the plaque will block blood flow through the vessel. Exercise and emotional stress cause angina. Decrease oxygen content in the air or you breathe. Flying or being at high altitude may trigger angina. Low blood flow to the heart, which occurs when you are in deep sleep, also can bring on angina. People commonly arrive at the emergency department in the early morning complaining of chest pain that awakened them from sleep, or the pain started after just going to the bathroom. Except coronary artery atherosclerosis and vasospasm, vasoconstriction can cause angina. Coronary spasm, also called variant angina princemetal. Variant angina typically occurs when patients are at rest. In this picture you can see a narrowed artery due to deposition of cholesterol due to formation of atherosclerotic plaque. And the first signs and symptoms of ischemic heart disease appears if diameter of coronary artery less than 65%. Incidence of angina continuously rises with age in women, while in men the incidence of angina peaks between 55 and 65 years of age before declining. Also, angina pectoris is of great interest. There is a lack of data on a community-wide basis because it is very difficult to study. Many cases are undetected, and it is very likely that only a small fraction of cases reach specialist clinics. Angina pectoris have a typical characteristics. Ischemic cardiac chest pain characterized by location, central, diffuse, substernal pain, radiation to the jaw, neck, shoulder, arm, or back. Character of angina pain: burning, squeezing, pressing, tight pain. And usually duration of angina pectoris less than 15 minutes, usually acute attack duration 3 to 5 minutes. Provoking factors: after physical exertion or emotional stress. And relieving factors: rest and nitroglycerin. Sublingually, quick response to nitrates. And maybe associated features such as breathlessness. Angina pectoris is a clinical syndrome, and verification and preliminary diagnosis we are established after inquiry, when we reveal typical location, radiation, typical character, typical duration, provoking factors, and relieving factors. Signs and symptoms of angina: maybe an uncomfortable pressure, fullness, squeezing or pain in the center of chest, pain spreading to shoulder, neck or arm and lasting more than few minutes, usually 3 to 5 minutes. It may feel like pressure, tightness, burning or heavy weight. It may be located in the chest, upper abdomen, back, neck, jaw, or inside arms or shoulders. Chest discomfort with light headedness. Anxiety, neurosis or fainting, sweating, nausea or shortness of breath. Increased or irregular heart rate associated with angina. Maybe paleness, cold sweaty skin, feeling of impending doom. Usually chest pain, angina pectoris, occur in atherosclerosis caused by insufficient blood flow from partial blockage of the coronary artery. Possible areas of radiating pain: neck, jaw, upper abdomen, shoulders, and arms, usually left-sided. typical man with angina. And in our clinical practice occur three main criteria of typical angina. Meets all three of the following characteristics. First criteria, substernal chest discomfort or characteristic quality and duration. Second criteria, provoked by exertion or emotional stress. And third criteria, relieved by rest and or nitrates within minutes. Short-acting nitrates, nitroglycerin sublingually. Three main criteria associated with typical angina. In atypical angina, probable angina meets two of these characteristics, and non-anginal chest pain lacks or meets only one or none of the characteristics. In this case, occur cardialgia. Types of angina pectoris in our clinical practice occur stable angina, unstable angina, princemetal angina, angiospastic, and microvascular angina. Stable angina is a repeating pattern of the chest pain which has not changed in character, frequency, intensity, or duration for several weeks. The level of activity or stress that provokes angina is predictable and the pattern changes slowly. Stable angina is the most common form and it appears gradually. These patients have an increased risk of a heart attack, but an episode of stable angina does not indicate that a heart attack is about to happen. A crucial component of the management of the pain associated with angina pectoris is identifying sources of stress and creating effective methods to minimize stress. Relaxation techniques to reduce stress include meditation, listening to music, play, or exercise. The reasons for the benefits that emerge after a coronary patient implements relaxation techniques are not clear. However, important roles appear to be played by central neural transmitters, including serotonin, melatonin, epinephrine, and dopamine. Stable angina divided into four functional classes according Canadian Cardiovascular Society. Functional classification. Canadian Cardiovascular Society separates patients with angina into groups based on severity of their symptoms. First class of angina stable angina pectoris, characterized by no limitation of ordinary activity, walking or climbing stairs does not cause angina, Angina may occur with unusual strenuous, rapid, or prolonged exertion. Second class of stable angina. Slight limitation of ordinary activity. Angina may occur with walking or climbing stairs rapidly and or walking more than 200 meters or climbing more than one flight of stairs at a normal pace and in normal condition. Third class of stable angina. Marked limitation of ordinary activity. Angina may occur after walking from 100 to 200 meters or climbing one flight of stairs at a normal pace and in normal condition. Fourth class of stable angina. Unable to carry on any physical activity without chest discomfort. Angina may occur after walking less than 100 meters, may be present at rest. The same classification. First class, angina only with strenuous exertion. Second class, angina with moderate exertion, slight limitation of ordinary activity. Third class, angina with mild exertion. And fourth class, angina at rest. No exertion needed to trigger angina. Unstable angina. The chest pain is variable, either increasing in frequency or intensity, and with irregular timing or duration. Unlike stable angina, unstable angina does not appear gradually. It first appears as a severe episode. An established stable angina might change suddenly or be provoked by less stress than in the past, or an episode might suddenly occur while at rest. If the pattern of an episode changes, for example, of a previous episode was only brought on during physical exertion, but an episode suddenly occurred at rest, it is likely to be unstable angina. Unstable angina, it is acute ischemia, duration of which not enough for development of ischemic necrosis. Variants of unstable angina. New onset angina from first clinical signs of substernal pain till 28 days. New onset angina. Second variant, progressive angina pectoris, increased intensity and duration of pain, increased quantity of attacks, appearance angina at rest and or at night, increased class of angina, progressive decreased tolerance to physical exertion, and transient ischemic changes on ECG at rest. And third variant of unstable angina, early post-myocardial infarction angina pectoris from 3 to 28 days. The main difference between stable and unstable angina. In stable angina occur fixed stenosis. In unstable angina, acute ischemia due to dynamic stenosis. In stable angina, demand-led ischemia. In unstable angina, supply-led ischemia. In stable angina, related to effort. Unstable angina, symptoms at rest. Unpredictable, unstable angina. Stable angina, predictable. In stable angina, symptoms occur over long term. In unstable, symptoms over short term. In stable angina, symptoms on minimal exertion. In unstable, frequent or nocturnal symptoms. And ECG changes, exercise test, duration of exercise, degree of ECG changes, abnormal BP. And in unstable angina, ECG changes at rest maybe, and ECG changes with symptoms. Vasospastic angina or Prince metal angina. Prince metal or spontaneous or angiospastic angina is caused by vasospasm and spasm that narrows the coronary artery and lessens the blood flow to the heart. Prince metal angina usually occurs in arteries already narrowed by atherosclerosis. In fact, most people with it have severe coronary atherosclerosis in at least one major vessel. Spasm usually occurs very close to the blockage. Unlike stable and unstable angina, Prince metal angina usually occurs when a person at rest or sleep, often at night, and not after physical exertion or emotional stress. It's associated with acute MI, severe cardiac arrhythmias, including ventricular tachycardia and ventricular fibrillation, and sudden coronary death. Microvascular angina or stable angina on angiographically intact vessels or coronary syndrome X. Microvascular angina occurs when the patient experiences chest pain but has no apparent coronary artery blockage. This condition results from poor functioning of the tiny blood vessels that nourish the heart, arms, and legs. Microvascular angina can occur during exercise or at rest. Reduced vasodilator capacity of the coronary microvessels is thought to be a cause of angina during exercise, but the mechanism of angina at rest is not known. Coronary microvascular spasm and resultant myocardial ischemia may be the cause of chest pain in a subgroup of patients with microvascular angina. %10 of all patients with ischemic heart disease suffered from microvascular angina. Microvascular angina or coronary syndrome X characterized by three specific typical signs as first, classic angina chest pain with typical characteristics. Second criteria, ST segment depression on ECG during stress test. And third, angiographically normal coronary arteries without left ventricle dysfunction on echocardiography. Diagnosis of angina is clinical diagnosis. After inquiry, we reveal typical characteristics of the substernal chest pain, and the diagnosis usually involves a careful assessment and history of signs and symptoms. Diagnostic procedures to exclude angina or establish the severity of coronary heart disease include ECG, stress test, and angiography. And laboratory investigation, obligative laboratory investigation, routine investigation include CBC, lipid profile, coagulogram, investigation of cardiospecific enzymes, AST, ALT at first, glucose, laboratory methods of investigation, obligatory routine indicators, routine parameters, blood analysis, common blood analysis, lipid profile, which include total cholesterol, high density cholesterol level, low density cholesterol level, triglycerides, glucose, AST, ALT, creatinine for calculation of glomerular filtration rate. And if we suspect acute coronary syndrome, we must do cardiac troponins and additional indicators of ischemic heart disease for exclusion of ischemic heart disease, thyroid hormones T3, T4, TTH. Instrumental methods include resting ECG, and on ECG during attack of angina can reveal changes of ST segment, ST depression or ST elevation with or without T-wave inversion at the time the patient is experiencing symptoms. It's reversible changes, reversible ST changes. And exercise ECG includes standard treadmill or bicycle ergometer protocol. Planar or downsloping ST depression of 1 mm or more is indicative of myocardial ischemia during exercise testing. Holter monitoring ECG during 24 hours, maybe 48 or 72 hours. Simple method for investigation of painless variant of ischemia. Myocardial perfusion scanning helpful in patients who are unable to exercise. Its predictive accuracy is higher than that of the exercise ECG. Stress echocardiography to identify ischemic segment of myocardial and areas of infarction, exhibit reversible defects in contractility during exercise or pharmacological stress with dobutamine. Gold standard of diagnosis of ischemic heart disease coronary angiography provides detailed anatomical information about the extent and nature of coronary artery disease and is usually performed with a view to coronary bypass grafting or PCI, percutaneous coronary intervention. May be indicated when non-invasive tests have failed to elucidate the cause of atypical chest pain. Patients with angina and or dyspnea and suspected coronary artery disease, resting echocardiography and CMR. Resting transthoracic echocardiogram is recommended in all patients for first, exclusion of alternative causes of angina. Second, identification of regional wall motion abnormalities suggestive of coronary artery disease. Measurement of left ventricle ejection fraction for risk stratification purpose. Evaluation of diastolic function. In this picture, you can see ECG with subendocardial ischemia. ST depression we reveal in first, second, AVL, and from V1 to V6 chest leads. Extensive subendocardial ischemia of anterior wall, septum, apex, and lateral wall. During attack of angina, acute ischemia. And in this picture, you can see ST elevation in first, limb lead AVL, and from V2 to V5 chest leads, and ST depression in third AVF. ST elevation usually characterized by transmural ischemia and development of acute MI. Extensive anterior MI with injury of anterior wall, septum, apex, and lateral wall. On angiography, you can see left coronary artery, left circumflex coronary artery, and left anterior descending coronary artery. The management of angina pectoris involves a careful assessment of the likely extent and severity of coronary artery disease, the identification and control of significant risk factors, the use of measures to control symptoms, the identification of high-risk patients, and application of treatment to improve life expectancy. Lifestyle modification include recommendation for diet. At first, saturated fatty acids to account for less than 10% of total energy intake through replacement by polyunsaturated fatty acids. Transunsaturated fatty acids less than 1% of total energy intake. Less than 5 grams of salt per day. 30 to 45 grams of fiber per day from whole grain products, fruits and vegetables. 200 grams of fruit per day and 200 grams of vegetables per day. Fish at least twice a week, one being oily fish. Consumption of alcoholic beverages should be limited to 2 glasses per day, 20 grams per day of alcohol for men and 1 glass per day, 10 grams per day of alcohol for non-pregnant women. A very diet with fish, with products of fruits, vegetables. And lifestyle management, except diet, include stop smoking, include control of risk factors, which can cause development of ischemic heart disease, and minimization of action of risk factors or excluding of risk factors, such as normalization of glucose if diabetic patients, and decrease body weight and adequate physical activity, exclude fatty food diet, normalization of blood pressure, control of lipids profile, liquidation of emotional stress, and medical management of patients with stable coronary artery disease, management of angina pectoris, include two main directions. First direction, angina relief and anti-ischemic therapy. And second direction, event prevention, and drugs which improve prognosis. For angina relief, we used short-acting nitrates, nitroglycerin sublingually, plus first line of anti-ischemic drugs, beta blockers or calcium channel blockers, which decrease heart rate, such as verapamil or diltiazem. And consider calcium channel blockers dihydropyridine origin, that if low heart rate or intolerance or contraindications for beta blockers. Calcium channel blockers dihydropyridine origin, amlodipine, lercanidipine, felodipine. Consider combination beta blockers plus calcium channel blockers dihydropyridine origin if angina more than second functional class. If no result, if ineffective combination beta blockers with calcium channel blockers, can use second line of management, second line of drugs, may add or switch first line for some cases. And second line of drugs include ivabradine, long-acting nitrates, such as isosorbitol dinitrate and isosorbitol mononitrate, nicorandil, ranolazine, trimetazidine. And if combination of second line of management ineffective, we are consider angiography and further invasive strategy, percutaneous coronary intervention, stenting, or CABG, bypass graft, coronary artery bypass graft. Second direction include non-pharmacological methods, lifestyle modification with control of risk factors, and education of patient, and pharmacological management, which include anti-aggregants, aspirin at first, hypolipidemic drugs, statins at first, and consider angiotensin converting enzyme inhibitors or angiotensin receptor blockers. Management of stable angina, step by step. First step, standard therapy, beta blockers or calcium channel blockers can use, and depends of hemodynamic changes. If stable hemodynamic, beta blockers, and if tachycardia present, beta blockers or non-dihydropyridine origin calcium channel blockers such as verapamil or diltiazem. If low heart rate, we use dihydropyridine origin calcium channel blockers such as amlodipine, lercanidipine, felodipine. If left ventricle dysfunction occur in heart failure, first step, beta blockers. If low blood pressure in stable angina, we use low dose of beta blockers or low dose of non-dihydropyridine origin calcium channel blockers. Step 2. Combination of beta blockers plus dihydropyridine calcium channel blockers. If heart rate more than 80, if we reveal tachycardia, combination beta blockers plus calcium channel blockers, non-dihydropyridine origin verapamil or diltiazem. If low heart rate, less than 50 beats per minute, and switch to long-acting nitrates, isosorbitadinitrate or isosorbitamononitrate. If we reveal left ventricle dysfunction or heart failure on echocardiography, we use combination beta blockers plus long-acting nitrates or beta blockers plus ivabradine. Ivabradine is a potassium channel activator and decrease heart rate but no action on arterial pressure. Ivabradine we use for if heart rate more than 70 and sinus rhythm. If sinus rhythm. And action of ivabradine like beta blockers decrease heart rate and increase diastole. And if you remember, coronary circulation occur in diastole. And due to increase diastole duration, anti-ischemic effect. Step 3, combination of 3 drugs in standard therapy and second-line drugs, and can use beta blockers plus ivabradine plus calcium channel blockers. If low heart rate, dihydropyridine origin, dihydropyridine calcium channel blockers like amlodipine and felodipine plus long-acting nitrates. If left ventricle dysfunction or low heart or heart failure we reveal on echocardiography, add another second-line drug. And if low blood pressure in stable angina, in third step, combine 2 second-line drugs. Step 4, combination 3 or 4 or more drugs. Add nicorandil, ranolazine, or trimetazidine. Nitroglycerin, short-acting drug. It mainly relaxes the veins and the peripheral vasodilator. And we are used in acute attack of angina, relaxing the veins. It reduces the amount of blood that returns to the heart and eases the heart workload. By relaxing the coronary arteries, it increases the heart blood supply. And the main anti-ischemic drugs, beta blockers and calcium channel blockers. Beta blockers causes decreased heart rate and increase diastole. Anti-ischemic drugs, first line, beta blockers like metoprolol, bisoprolol, nebivolol, carvedilol. Calcium channel blockers, non-dehydropyridine origin, verapamil and diltiazem can use if beta blockers contraindicated. And calcium channel blockers dehydropyridine origin, amlodipine, felodipine and lercanidipine. Second line include nitrates, isosorbitol-dinitrate and isosorbitol-mononitrate. Long-acting nitrates for prevention of ischemic attack, for prevention of angina pectoris. Drugs which improve prognosis, antiplatelet drugs such as aspirin, clopidogrel. If aspirin contraindicated in peptic ulcer, we use clopidogrel. Hypolipidemic drugs, at first statins, lovastatin, simvastatin, atorvastatin, rosuvastatin we are used in ischemic heart disease for decrease total cholesterol and low density cholesterol level. Beta blockers are the main anti-ischemic drugs, and except anti-ischemic effect, beta blockers improve prognosis. decrease mortality and decrease risk of sudden death. ACE inhibitors: enalapril, lisinopril, perindopril, ramipril. Group of drugs, this medicines, this group have a wide spectrum of action, cardioprotective action. And in ischemic heart disease, we use ACE inhibitors for prevention of remodelation of myocardium, for prevention of changes of structure of myocardium, for prevention of hypertrophy, dilation of myocardium in low doses. Because ACE inhibitors can cause hypertension. Controlling the risk factors for angina, such as high blood pressure, cigarette smoking, high cholesterol level, and excess weight, is an essential part of treatment. And antiplatelets, low doses of aspirin, 75 to 100, 150 maybe, reduces the risk of adverse events such as myocardial infarction and should be prescribed for all patients. Clopidogrel 75 mg is an equally effective agent that can be prescribed if aspirin causes dyspepsia or other side effects. In peptic ulcer, aspirin contraindicated. We use clopidogrel. What procedures are used to treat angina? Except pharmacological management, invasive techniques that improve the heart and the heart blood supply also may be used. One of these, percutaneous coronary intervention, PCI. In it, a thin, flexible plastic tube catheter with a balloon is inserted into artery and advanced to the blockage. Then the balloon is inflated, squeezing open the fatty plaque deposit. Then the balloon is deflated and the catheter is withdrawn. Often a stent is also placed to hold the artery open. Two additional techniques used to reduce coronary blockage are laser angioplasty and atherectomy. In laser angioplasty, a catheter with a laser on its tip is used to open the blockage. In atherectomy, a catheter has a rotating shaver on its tip to cut away to the plaque. These techniques also may be accompanied by stent placement. Coronary artery bypass graft surgery is also used. In it, a blood vessel is used to route blood around the blockade part of the artery, forming a kind of detour. Before performing any of these procedures, a doctor must find the blockaded parts of the coronary arteries. This requires coronary arteriography, which is done during cardiac catheterization. In this procedure, a doctor guides a catheter through an artery in the arm or leg into the coronary arteries. Then the doctor injects a liquid dye through the catheter High-speed X-ray moves record the course of dye as it flows through the arteries. Doctors can identify blockage by tracing the flow. An evaluation of how the heart works also can done during cardiac catheterization. Other tests can be used to evaluate how well the heart works and may be done before or after a heart attack. And percutaneous coronary intervention and coronary artery bypass graft surgery were used in case when pharmacological management ineffective. After coronary angiography, can use invasive strategy. How is variant angina or prince-metal angina treated? Calcium antagonists are extremely effective in preventing the coronary spasm of variant or prince-metal angina. These drugs, along with nitrates, are the mainstays of treatment. Prince-metal angina tends to be cyclic, appearing for a time, then going away. Because of this, after 6 to 12 months of treatment, the calcium antagonist may be gradually reduced. In some cases, percutaneous coronary intervention or surgery are used when blockage exists along with spasm. Pharmacological management. If patient come to the hospital emergency department, you may be sent to another care area for further testing, treatment, or observation. On the basis of your provider's preliminary diagnosis, you may be sent to the following units: an observation unit pending test results or further testing, a cardiac care unit, a cardiac catheterization unit, the operating room for emergency cardiac bypass surgery. Regardless of where you are sent, several basic treatments may be started, which are given to you depends on severity of your symptoms and the underlying disease. You will have at least one intravenous line started. This line is used to give medication or fluids. You will probably be given an aspirin if you haven't already taken one. You may be given oxygen through a face mask or a tube in your nose. This will help you feel better if you are having trouble breathing or feeling uncomfortably short of breath by raising the oxygen content of your blood. And if you reveal saturation less than 90%, we use oxygen therapy. Medical treatment depends on severity of symptoms, severity of underlying disease, and extent of damage to the heart muscle, if any. Simple rest and observation, and aspirin, breathing oxygen, and sublingual nitroglycerin may be all that you need if it is only angina. You may be given medication to reduce anxiety or to treat pain. We repeat. Beta blockers, angiotensin converting enzyme inhibitors, beta blockers as anti-ischemic drugs, AC inhibitors as drugs which improve prognosis, and cholesterol-lowering drugs as the same drugs which improve prognosis for prevention of complications. Commonly given if the chance of a heart attack are likely. Cardiometabolic therapy. At first, cardiocytoprotectors, trimetazidine, and its second line of anti-ischemic therapy, cardiocytoprotector, and other cardiometabolic drugs can use in ischemic heart disease, like ribaxin, mildronate, tiotriazoline, vitamins, and antioxidants. With additional management, no improved prognosis. I repeat, invasive strategy, angioplasty, PCI, percutaneous coronary intervention. Angioplasty and stenting is a treatment used for people whose angina does not get better with pharmacological management, and patients with high or very high risk of complications. Before angioplasty can be done, the areas of coronary artery narrowing is located with coronary angiography. A thin plastic tube called a catheter is inserted into artery in the arms or groin with local sedation. The catheter has a teeny balloon attached to the end. The catheter is treated through the arteries and into the artery where the narrowing is. The balloon is inflated, opening up the narrowing. This is not a permanent solution for most people. Many require placement of a stent, a small metal sleeve that is placed in the narrowed artery. The stent holds the artery open. Catheter entrance into femoral artery or radial artery, and balloon-tipped tube is inserted in coronary artery. Balloon is expanded several times. And stent insertion, stent expansion, and stent remains in coronary artery. Restoration of coronary circulation. And information about European Society Cardiology's guidelines 2019. on the diagnosis and management of chronic coronary syndromes. And guidelines have been revised to focus on CCS instead of stable coronary artery disease. This change emphasizes the fact that the clinical presentations of coronary artery disease can be categorized as either acute coronary syndrome or chronic coronary syndrome. In the current guidelines on chronic coronary syndrome, 6 clinical scenarios most frequently encountered in patients are identified. First, patients with suspected coronary artery disease and stable inguinal symptoms and or dyspnea. Second variant, patients with new onset of heart failure or left ventricle dysfunction are suspected coronary artery disease. Third variant, asymptomatic and symptomatic patients with stabilized symptoms less than 1 year after and acute coronary syndrome or patients with recent revascularization. Fourth variant, asymptomatic and symptomatic patients more than 1 year after initial diagnosis or revascularization. Fifth variant, patients with angina and suspected vasospastic or microvascular disease. And sixth variant, asymptomatic subjects in whom coronary artery disease is detected at screening. Painless variant. Six variants of chronic coronary syndrome. The pretest probabilities of coronary artery disease based on age, gender, and nature of symptoms have undergone major revisions. In addition, we introduces the new phrase clinical likelihood of coronary artery disease that utilizes also various risk factors of coronary artery disease as pretest probabilities modifiers. The application of various diagnostic tests in different patient groups to rule in or rule out coronary artery disease have been updated. The guidelines emphasize the crucial role of healthy lifestyle behaviors and other preventive actions in decreasing the risk of subsequent cardiovascular events and mortality. Basic testing, diagnostics, and risk assessment. A non-invasive functional imaging or coronary CTA as the initial test for diagnosing coronary artery disease. Initial non-invasive diagnostic test based on the clinical likelihood of coronary artery disease, patient's characteristics, local expertise, and availability. Functional imaging for myocardial ischemia if coronary CTA has shown coronary artery disease of uncertain functional significance or is not diagnostic. Invasive angiography to diagnose coronary artery disease in patients with a high clinical likelihood and severe symptoms refractory to medical therapy. Typical angina at low level of exercise and clinical evaluation that indicates high event risk. Invasive functional assessment must be available and used to evaluate stenosis before revascularization, unless very high grade, more than 90% diameter stenosis. Invasive coronary angiography with availability of invasive functional evaluation for confirmation of coronary artery disease diagnosis in patients with uncertain diagnosis on non-invasive testing. Coronary CTA as an alternative to invasive angiography if another non-invasive test is equivocal or non-diagnostic. And coronary CTA when any conditions make good image quality unlikely. Antithrombotic therapy in patients with chronic coronary syndrome and sinus rhythm. Adding a second antithrombotic drug to aspirin for long-term secondary prevention in patients with high risk of ischemic events and without high bleeding risk. Adding a second antithrombotic drug to aspirin for long-term secondary prevention in patients with at least a moderately increased risk of ischemic events and without high bleeding risk. Antithrombotic therapy in patients with chronic coronary syndrome and atrial fibrillation. Non-oral anticoagulates is recommended in preference to a VKA. Long-term oral anticoagulants therapy in patients with atrial fibrillation and CHADS-2 VASC score more than 2 in males and more than 3 in females. Long-term oral anticoagulants therapy in patients with atrial fibrillation and CHADS-2 VASC score in 1 in males and 2 in females. Antithrombotic therapy in post-percutaneous coronary intervention patients with indication for oral anticoagulants. Full dose non-oral anticoagulants is recommended in preference to a VKA. Rivaroxaban 15 mg over 20 mg. Dabigatran 110 mg over 150 mg. Early cessation less than 1 week of aspirin. Triple therapy for 1 to 6 months. International ratio 2 to 2.5 and TTR more than 70 if VKA. Dual therapy with prasugrel or ticagrelor over clopidogrel. As a pharmacological therapy, thank you for attention. Be healthy. Goodbye. Goodbye, students. really